Okay, Assalamualaikum and good morning everyone. My name is Dr. Nasrina and thank you for joining us for a short CME today with our invited speaker, Dr. Abdul Hanif Khan. So just for some introduction, as we all know that actually last month we celebrated World Stroke Day, and this will be continuous until next year. So in conjunction with this, we started to have more and more awareness about brain attack, and there are more options of treatment available if the patient come in time. And being in HPJ, we actually we do have a stroke network, and we refer out the patients who are eligible for further management and intervention to HPUPM. So today we are very fortunate to have Dr. Abdul Hanif Khan, Yusuf Khan. He's an internal medicine physician, neurology fellow, and a medical lecturer, currently working in HPUPM. He obtained his medical degree from Royal College of Surgeons in Ireland in 2010, and subsequently received his master in medicine from University Putra Malaysia in 2018. So his main interest of research and study is in stroke, mainly on the interventional aspect, and he's also active in doing research such as in congenital myotonia and research involving non-invasive procedures for rehabilitation such as transcranial direct current stimulation. And he's also very active involving in Malaysia stroke certification, okay, and he's the head coordinator, and also he is the executive secretariat member of society in the Asian Oceanic Association of Neurology. And me and Hanif, we know each other since 2010, Hanif. It has been a very long, awesome friendship. It's glad to know that you are a neurologist. I'm interested in neuro as well. So without further ado, I would like to invite Dr. Hanif to share and deliver his lecture for today. And just a bit of a housekeeping announcement. If you have any questions, you can either type it in the chat box, or you can unmute yourself to ask to Dr. Hanif at the end of the of his lecture. Thank you.
Assalamualaikum, and thank you for the kind introduction, Dr. Nasrina. Dr. Nasrina actually my MO masa I houseman dulu. He was in emergency. He was one of the nice MO that we work with. Apa nama dia? This is not really a lecture, but it's just a sharing session for apa nama dia? So for stroke recognition, and also let me share my screen first. May I know before that who is my audience? Yeah? Sebab kita pun tak ramai. Nanti kalau we want to make it informal pun is okay.
For your information, we have our head of department, Dr. Khairul Nizam, also joining, and also our fellow EPs. And also our MOs and housemen.
Great. So we have a wide variety of participants. So actually, the main reason I for this talk, as macam Dr. Nasrina approached to me, is basically because we're getting a lot of stroke referrals daripada HPJ, which we are very grateful, and the sending pun very fast. So so mainly my talk, my sharing session rather than my lecture or anything today would be mainly related to the stroke recognition, basically in the hyperacute stroke, and how do you want to determine whether this is a cortical stroke, whether this is a lacuna stroke, whether it's a LVO or something like that, so that we can actually stratify in terms of, kadang kita pun nak bagi tahu semua orang pasal thrombectomy cost tu pun sebenarnya not everyone will be required the thrombectomy, especially if those with the lacuna non-cortical strokes. So this is very important for the MOs and for the housemen actually to identify the signs in the patient, so that you can actually give takut kadang bila kita cakap 30,000 tu dekat patient pun dah takut dia tak nak datang kan. So if we actually kalau kita bagi tahu, okay, basic nampak macam patient ni hanya perlu thrombolysis saja. Kalau perlu thrombolysis saja, memang dia orang tak perlu pun nak keluarkan deposit untuk thrombectomy yang tu sekarang. So this is important for me to, and also siapa yang kita kita nak refer rather than kita refer yang kalau boleh kalau kita memang nak dapat semua stroke kan, tapi certain stroke yang memang dah couple of days atau dah lambat yang memang kita rasa memang kita tak ada any intervention that we can do, maybe we no need to refer, and then maybe those the hyperacute stroke then kita refer. Okay, so without further ado, I go proceed to my sharing session. I share my screen. Can everyone see my screen? Tenas, can you see my screen? Okay?
Yes, we can.
Okay, great. Okay, so this is the layout of my presentation. I will talk about definition of stroke, the basic pathophysiology, the stroke classification, the clinical features, and I will talk about the hyperacute stroke, whether what we're going to do in terms of intravenous thrombolysis or mechanical thrombectomy, and the case example. This case example is actually during that weekend at on call. All these 4 cases actually 2 from Putrajaya. So I just want to see actually that weekend we had a variety of cases with multiple other different scenarios. So I just go through a bit on the basic and clinical feature. This is basically for the MOs and also for the houseman, so that you guys know a bit more on the basic of the stroke. So what's the definition? This is all kita dapat daripada our latest CPG that was published in this year, in 2020. So this information all can get from there. So basically, stroke is defined as brain, spinal cord, or retinal cell death attributable to ischemia based on pathological imaging or objective evidence. So kalau nak cakap patient is sebenarnya stroke is actually a clinical diagnosis, especially if patient have clinical evidence of ischemic injury, and plus dia yang different sikit yang stroke definition is dia orang tambah is actually there must be evidence of ischemic injury, either from imaging atau daripada clinical evidence. So for us to label them as stroke, if there's no evidence of ischemic injury, either from the imaging or is resolved, so we call it TIA rather than a stroke. So this is an important classification that definition that is being updated. Then the symptom persists for greater than 24 hours. So as we know, stroke can be classified according to the hours. So the 2 that we are interested in, we're interested in all, but the 2 that we can actually do something about it is your early hyperacute. That is that stroke that occurs between that 0 and 6 hours. Where this patient usually they have the more evidence for thrombolysis and thrombectomy, or the late hyperacute within 6 to 24 hours. Where this patient is based on your advanced imaging, we can determine whether they will benefit from the intervention or not. Otherwise, all these patients, sebenarnya this is very important as well. This group of patients, acute, subacute, and chronic, we want to prevent further stroke and intensive rehab. We are very fortunate here in HPUPM, where our rehab team is very aggressive and very prominent in terms of managing the rehabilitation part of our stroke patients. So as we know, this is a basic pathophysiology of stroke. The most common cause still is your atherothrombosis of the large vessel, and importantly, secondly, is your intracranial small vessel disease. This is majority we see in those lacuna infarcts, especially the one with the poorly controlled hypertension, poorly controlled diabetic, and another 20% will be your embolism, especially patient with AF. Others, for example, all those young stroke with SLE, fibromuscular dysplasia, aortic dissection, those kind of stuff. And cryptogenic is, despite extensive investigation, we couldn't find the cause of stroke. This is what we call, sometimes we label them as ISAS, embolic stroke of undetermined significant. So we actually need to sebenarnya most of the cryptogenic stroke, the thoughts at the moment is either those AF that we haven't detected, or PFOs. Now a lot of research are doing for us to really look for PFOs, which is your pattern foramen ovale, for the cause of stroke in this cryptogenic patient. So what are the atherothrombosis of the large vessel? Atherothrombosis is defined as the atherosclerosis with superimposed thrombosis, where atherosclerosis affect the large and medium vessel arteries. Basically the same thing as your heart. We started with a plug will rupture, and then it form a thrombus. The same thing with your, the same thing that happened in our heart attack, but occurs in the vessel of the brain. And this is something that is actually quite unique to our population, which is intracranial large artery disease, what we call ICAT. ICAT is something that we call, it's not prominent in the Western, because that's why there's a lot of, not much research is being done, because this is the disease of the Asian population, because because we're doing a lot of MRAs and in a lot of our patients, so we present a lot of us have what we call atherosclerosis of the large vessel, we call ICAT. So this is something that is a lot of interest are doing, especially us in our interventional radiologists, because whether this group of patient what we call will benefit from stenting of the vessel. The same thing with your heart, but it's linked together, but compared, this is the vessel of the brain. So this is something that is ongoing research at the moment. So this is your what we call intracranial small vessel disease. This is basically is due to lymphonolysis, microerythema, and fibrinate necrosis. So mainly all of these are due to the common vascular risk factor, most likely hypertension, smoking, diabetes. Atrial fibrillation usually is your embolism, but basically all your normal risk factors. If they have this, their pathophysiology, what we call usually intracranial small vessel disease. So embolism, no need to, basically patient with atrial fibrillation presented with the embolus or anything like that. So it's important for us to detect atrial fibrillation and valvular heart disease in this group of population. Yeah, others will be, this is it's actually quite rare, especially we see in the young patient. For example, atrial dissection. We see a lot of atrial dissection at the moment. Hari tu pun ada couple of case that we got the dissection as a cause of stroke. Fibromuscular dysplasia, vasculitis, moya-moya. Moya-moya pun banyak sekarang. We seen a lot of moya-moya, hypercoagulable state, metabolic disorder, CADASIL and those kind of stuff. So this is actually not quite common. And lastly, your cryptogenic. Cryptogenic is kita wouldn't find a cause despite a complete workup. It's a diagnosis of exclusion, and it account about 20 to 40%. It's actually quite tinggi juga the percentage, because a lot of patients with stroke that we couldn't identify the cause of the stroke. So as I mentioned before, the possible mechanism of this stroke is embolism secondary to occult paroxysmal atrial fibrillation. At the moment, we only be able, dekat HPUPM, we will only be able to do a halter for 24 hours. Tapi sebenarnya kalau ikut guideline from the from overseas ke apa, they need to be on halter for 2 weeks at least. Kita try to push for 72 hours. Our halter pun kadang tak boleh juga. So that's why a lot of yang cryptogenic stroke is still because of we haven't found the atrial fibrillation. So another thing will be your paradoxical embolism, especially now a lot of research on PFOs. So we're doing a lot of echo with bubble juga at the moment, because for our young patient with TCD with bubble, because we want to look for the PFOs. So hopefully if jumpa PFO, at the moment kita tak ada, kita ada beberapa hari tu ada terjumpa, we suspect PFO, but when we send for cardio for TOE, it's not, there's no PFOs. So this is the new terminology that we mentioned, is a non-lacuna cryptogenic stroke. This is what we call ISAS, embolic stroke of undetermined source. Okay. So what are the clinical features for the Houseman was your Clark patient. So dekat Malaysia ni, we use two widely classification of Oxford dengan TOS. Why is it easy for us to use this classification? Because Oxford is based on clinical findings saja. It doesn't need your radiological finding. For TOS classification, usually we already have the imaging done, and also we have some investigation done. So it's based on etiology. So we go to your Oxford classification. So this is something important that I want to emphasize to everyone. It's important when we refer a patient with stroke. So kita kena we need to inform our receiving end whether kita kena inform our receiving end whether patient ni kita suspect ada large vessel occlusion atau tak. What are the signs of the because kalau kita nak suspect ada large vessel occlusion, so we need to kita kena inform our angio suite for our angio suite and intervention radiologist to be prepared because most of the time dia orang tak ada dekat hospital tapi our neurologist will be around, so it's important masa refer to us, we must identify whether they have signs to suggest they have large vessel occlusion. So what are the signs that suggest ada large vessel occlusion? So in patient with large vessel occlusion, usually they have what we call cortical sign. Cortical sign means that if you see from the CT, basically, or this MRI, kalau cortical signs means that they involve the cortex. Involve the cortex means that usually this is your MCA distribution. Dia ada cortex. Tapi kalau your lacuna ke apa kan, it only involve your subcortical here. So this, you can see gambar ni cantik this is your corona radiata. So they involve only this one. So it doesn't touch your cortex over here. So most likely kalau kita tahu kalau dia dah involve cortex subcortical saja, most likely it's not a large vessel occlusion lah. It's most likely it's just what we call small vessel disease, which is your small vessel disease because of hypertension, polycontrol diabetic, and those kind of stuff. So what are those cortical signs? So when you clock the case, for example, your total anterior circulation syndrome, which involve your the whole cortex, they have what we call hemiparesis. Everyone will have hemiparesis, but they have a higher cortical function. So it's important for you to determine whether they have dysphasia or aphasia. Bukan dysarthria, means that dysphasia means that they cannot speak or they cannot name place, especially if the patient have a right-sided weakness. If a patient have the right-sided weakness, means that the dysphasia or aphasia usually involve your left brain, because most of the time your speech center is on the left side. About 90% of us, our speech center is in the left brain. So anyone with the right-sided weakness, then it's logical for them to have aphasia. So if they have right-sided weakness plus aphasia, you already think that they have what we call large vessel occlusion. But if they have left-sided weakness, so the brain that is affected is just your right side. Most likely they have neglect rather than they have aphasia. So it's a bit unlikely. I'm not saying that tak boleh. It's a bit unlikely if someone having a left-sided weakness with aphasia, because usually your aphasia is in the left brain. Okay, so those are the two signs that you need to look for: aphasia and also neglect. Kalau neglect ni is quite difficult to determine because sometimes it's being procured by your hemanopia. Tapi especially if your patient with the left-sided weakness, look for neglect rather than aphasia. Okay. So another important thing is your homonymous hemanophia, which means that they must have an eye sign. Either is I know it's quite difficult for us to do a visual field masa dekat dekat emergency, but something that is easier for us to see is sometimes we see a gaze preference. Kita tengok mata dia sebenarnya pandang sebelah mana. Kalau usually your MCA stroke, contohnya kalau dia right-sided weakness, dia akan always look away daripada lesion. Contohnya kalau dia right-sided weakness, dia punya gaze preference should be on the left. So my Prof Hamida selalu cakap orang right MCA stroke ni dia akan look away daripada lesion dia. Dia tak nak tengok lesion dia. Tapi in comparison with your brainstem, dia akan look towards the lesion. So kalau ada pontine infarct ke apa, dia akan the gaze preference is towards the lesion. So when you examine, especially with the big MCA, tengok ada gaze preference ke tak. Maknanya mata dia tengok sebelah mana. Okay, so those because mata tengok sebelah mana, we can actually say that patient have a homonymous hemanopia. Okay, so if they have to do all these three symptoms, most likely this is a MCA, huge MCA, or also ICA. So this is what we call a total anterior circulation syndrome. If they have either two of those, two of these we call partial. Usually the MCA branch juga, tapi usually your distal branch, either your M2 ke M3 ke. Nanti I will show you some picture. So kalau ni kalau MCA, this is kalau you dapat this ni, most likely this patient need a intervention for thrombectomy. So kalau dah ada je sign ni, quote them, they need thrombectomy. Even this one, either they have your cortical dysfunction or hemanopia, then maybe kita ada possible we do a thrombectomy. So usually M2, M3 kadang work well with just thrombolysis pun diorang dah, they only need angio. Something we need to understand is sometimes if they do angio ni dia tak kira cost. Angio ni kira macam just an intervention saja. So kalau ada GL, angio will cover. Cuma the problem will be the thrombectomy. Okay, so and then your posterior circulation, and it's a bit tricky lah, your posterior circulation, especially with the giddiness lah. Ada so kalau posterior circulation ni memang it's not so typical lah. Usually either your vascular or cerebellar, they have nausea, they have vomiting, they have giddiness, sometimes they have eye symptoms. But and then these are the most common we see, and they works and thrombolysis works very well with that. They have pure motor syndrome. Dia ada weakness saja, and then dysarthria. Tapi dia orang tak ada eye symptom, dia boleh bercakap lagi dengan you. Most likely those are just a lacuna syndrome, either pure motor, pure sensory, or sensory motor, ataxic hemiparesis. Usually what are the culprit because of those penetrating arteries, either in your basal ganglia or your pontine. So that's why sometimes when we see a lot, because we see a lot of pontine infarct, because we're doing a lot of MRI. Because kalau previously we do a lot of CT, so kita miss a lot of those pontine infarcts or those posterior circulation, and they behave exactly like your lacuna because they affect your penetrating arteries, your pontine branches. And those and usually because your cortical spinal tract will run dekat your pontine, so that's why they have just a pure motor. So in this patient, thrombolysis works very well, and even actually I katakan we need to inform you, tapi usually we know that this patient will not need thrombectomy and those kind of stuff. So this is something that when we assess the patient, we can actually tell them rather than we tell everyone they need a thrombectomy. Okay, so then that's your Oxford classification. Subsequently, your TOS classification based on etiology. So what etiology is either your large artery sclerosis. This is basically after we get the imaging and after we do some investigation, we got the AL, we got the ECG. Before we label them for large artery sclerosis, cardioembolic, small vessel disease, other determined and undetermined. Okay, so basically after us we admit them and then we give this classification on the etiology. So that kalau cardiac embolic, we really need to look hard for the, because usually your cardiac embolic dia can affect your cortex. And then because the throwing embolus, usually in this patient, diorang suddenly je, diorang history is sudden onset of weakness and then diorang terus jadi teruk. Because kalau orang cardiac embolic ni, usually they don't have a good collaterals in their brain. So that's why when they got a stroke, they get terus dia orang punya area mati. Compared to your small vessel disease or your large artery sclerosis ni, because it's a chronically insulting to the brain. So the brain have developed a good collateral. So when you take the history, dia kata, I mula lemah sikit-sikit je. Lepas tu makin lama makin teruk. So you know that those are actually either your ICAT or your small vessel disease, because the brain have the collateral to compensate. But as they go along, the compensation fail and they will have the weakness. Compared to the cardiac embolic, the presentation will be just fever, complete sudden weakness, terus teruk that time, and then they present to you. So those are the fine clues that we're going to take from the history to determine the cause of the stroke. Okay, so as I have mentioned before. Okay, let's go to your hyperacute management. So as you know, the goal for reperfusion therapy is for the immediate goal is to restore the blood flow to the regions of brain that are ischemic but not yet infarcted. So that's why the time is brain. So that we need to send them as fast as possible, so that we would like to save the brain that is not infarcted yet. And then the long-term goal is to improve the outcome by reducing the stroke-related disability and mortality. Because we don't want them to be disabled and we don't want them to die. So what are the options that are available? Either an intravenous thrombolysis, altiplase, and currently we are using hopefully we can use more tenecteplase, because apa yang bestnya tenecteplase is just one bolus je, rather than altiplase you need to give bolus and then you need to do the infusion, which is a bit leceh. So kalau TNK just one bolus, that's good. When we find that our tenecteplase is work better compared to the alteplase. And then the mechanical thrombectomy is either using stenting or aspiration. Later I will go through. Okay, this is intravenous thrombolysis. What are the indication and also the indication? So basically, if within window 4.5 hours, this is something I would like everyone to be aware. So who are the one who is will benefit from intravenous thrombosis? So the inclusion criteria is clinical diagnosis of ischemic stroke with measurable deficit. Okay, so kalau kita nak be a very rigid, kita hanya akan ambil orang with NIHS more than 5. Tetapi we have to know some patient even with mild stroke tapi dia ada measurable neurological deficit. Contohnya, these are the signs that what we call a considered neurological deficit. Contohnya dia ada eye symptom. Even diorang ada tak ada weakness sangat tapi diorang ada hemanopia. Means that is actually very significant, then we need to thrombolyze regardless if it's a low NIHS. So sama ada aphasia, or even now, even the latest JAMA punya guideline, they call even dysarthria, severe dysarthria pun considered as a measurable, because we don't want people to become dysarthric, especially if patient who is higher function, someone which is a lecturer, someone is teacher, even normal people, we don't want them to be dysarthric. So this is still considered a significant deficit. So we need to do, even their deficit is just dysarthria, we need to do something about it, because this is something disabled to the patient. And then even weakness, something very easy for us to do masa dekat emergency, ask them to naikkan dua-dua tangan je and then count to 10. If they cannot sustain, or they terus drop to the bed, they will benefit from thrombolysis. So this is actually something very crude for us to do, because even for us when patient datang, kita tak adalah buat full NIHS, tapi we do a very important one, which is your motor. Just ask them to angkat both of their hand. If one dah drop, that's definitely significant disability. So they will benefit from thrombolysis. Any weakness limiting sustained effort against gravity, more than 2 on NIHS. Even diorang tak nampak macam severe, tapi kalau dah tak boleh sustain against gravity je, they are considered a measurable the neurological deficit, then they will benefit from thrombolysis. So that's why a lot of research now, a lot of people arguing, should we give even in your mild stroke thrombolysis, because so a lot of discussion going on that. So kalau tengok kat sini, sometimes someone with a mild stroke but we think like orang muda, and then this is a measurable deficit with them, then we still give. Later I'll give you an example for what I have done during that weekend. So the exclusion criteria, this is very important for us to take the history. Someone with the ischemic stroke for the past 3 months, any bleeding, any malignancy, kalau boleh ada checklist. Especially BP, kalau kita rasa kalau nampak BP dia sangat tinggi dekat Putrajaya kan, and you rasa this is a stroke that we need, even with bleed pun kita akan kurangkan BP kan. Kalau you guys memang nak send us for for thrombolysis, kalau boleh just give 5 mg labetalol dulu kat sana. Hopefully the BP bila datang kat kita dah rendah sikit, because kita orang ni, especially kalau patient dah BP tinggi sangat, after MRI kita rasa patient tu dah benefit from thrombolysis, kita orang still kena keluarkan patient, turunkan BP, so it will delay a lot of things. So hopefully kalau if we manage to bring down, at least give a 5 mg labetalol there in Putrajaya and then send to us, maknanya BP dia tak adalah tinggi sangat masa datang ke us, then we will not take so long to bring down the BP. Any active bleeding, this is something platelet less than 100. Kalau orang on warfarin, kalau iron more than 1.7, and this is important if patient ambil DOAC, kena tanya bila the last dose. Kalau within 48 hours kita tak thrombolyze lah. Sebenarnya sekarang orang kata 24 hours lah diorang bagi. Tapi it's important to tanya what kind of DOAC they take. If they take dabigatran, we have a reversal agent here. So we have used them twice. over here, patient with on dabigatran, and we reverse with idarucizumab, and then we thrombolize them. Unfortunately, the first patient that we used, he did well. He actually recovered from the stroke. Tapi he developed a lot of complications. He had an underlying lung problem, and then he developed complication from that. And then yesterday, the day before, we had another patient. We used idarucizumab, and then now we're waiting for his recovery. And if you done a HCT, evidence of hemorrhage and this kind of stuff. So this warning, tak perlu sangat lah. So what are the benefit benefit the risks kalau kita tengok kalau within 3 hours as you know, as we lagi cepat the number needed to treat to get the benefits only 10 tapi kalau dah lambat even to 4.5 hours, we need more patient to get the benefit. Number needed to treat about 20 kalau beyond 4.4 hours, number needed to treat is about 50. The risk kalau nak cakap how many percent of risk for bleeding, you can always say about the risk of symptomatic about 5% lah. Kita kan cakap orang about 5% of bleeding. So this is a nice nice cartoon lah if we that show patient. Sebenarnya this is a it's been published in stroke journal. You can see this is the, kalau tengok, this is our cohort of patient that is being thrombolized. Kalau tengok the benefit is actually these few people je. So that's why kalau boleh kita nak kejar these few people for us to give benefits. Then most of the patient ni yang hijau pekat ni will get benefit, they will recover completely. And then hijau biasa ni dia akan ada small recovery, and a lot, kalau tengok a lot of putih still they have no there's still no major changes. So that's why kita kalau kita nak dapat volume so that we can find these green patients. And then most of the time patient yang kita thrombolize pun tak ada major changes. As we know, that is actually what we call those are the statistic lah. And then 3 patient kalau tengok sini, those 1 akan mati and 2 akan ada bleeding atau become worse. Okay, so this is a nice representative if you want to show your patients. Not everyone will benefit, but there's few patients that will benefit a lot from it. Then most of them will have no changes from the thrombolysis. Okay. So another thing is extended hours. So although it's beyond 4.5 hours, which patient that how do we choose? Someone who will benefit from those extended, especially if one is a wake up stroke. Kalau important masih tanya, patient bangun dengan stroke ke atau dia dah bangun, dia dah semayang dulu, dah pergi toilet ke, and then dia dapat stroke. So important my history, whether you want to tell us this is a wake up or not. Kalau we know that this is a wake up, we need to do a advanced imaging. So the imaging that we can do is our DWI flare mismatch. Later I will show you on the MRI, real MRI, what does a DWI flare mismatch means. When there's a mismatch, they will benefit from thrombolysis. So those are the extended hours. So important to tell us whether this is a wake up stroke or not. Secondly is from the extend trial, we can actually include extend up to 9 hours. This is based on perfusion. So unfortunately kat sini we didn't do a lot of perfusion, but we do a lot of flare mismatch. So there's a calculation using your what we call rapid imaging. It's a AI to determine whether this patient will benefit from treatment ke tak. So all of this we need to send here because we need to do some advanced imaging, either CT or MR perfusion. Okay, so remember for extend trial is up to 9 hours or wake up, and then your wake up trial will be your wake up stroke. Okay, now we go to what we call the mechanical thrombectomy. So for the houseman or medical officer, I just want to tell you what do we call your large vessel occlusion. As you can see from this cartoon. So this is your internal carotid artery. So any occlusion at here, internal carotid artery, and then to your what we call M1. This is your M1. So this is what we call considered a large vessel occlusion. So this is your penetrating arteries. This is all your basically your lacuna infarcts, all because of this penetrating arteries. And then if the lesion is either at M1 or at A1, we consider that A1 will be your anterior circulation, your anterior cerebral artery. So an addition over here from the internal carotid to M1 and A1, we consider them as a large vessel occlusion. And some people are more comfortable even to take M2. But M2 is more challenging to do. So tapi kalau dia M2 or M3 ni, dia what we call a distal vessel occlusion, DVO. This patient will benefit from thrombolysis. Someone with M2 over the M3 thrombosis or with the lentrochostriatritis. Tapi kalau M1 dengan A1, we consider them as a large vessel occlusion. So what are the indication if within 6 hours a clinical diagnosis of stroke NIHS more than 6 or any potentially disabling stroke aspect more than 6 on contrast CT. I won't go through about aspect. And then brain CT or MRI to rule out intracranial hemorrhage, or as I mentioned, there must have evidence of LVO over the ICA or M1 or M2. M2 ni is actually technically challenging, but some people will go through M2 as well, or A1 or A2, and age more than 18 years old. So how about those extended hours? How do we determine that? Kalau based on the Dawn trial, between 6 to 24 hours. So either they fail or contraindicated for intravenous thrombolysis. So deficit more than 10. How do we determine? Is by this. There's evidence of clinical core mismatch. How do you want to do this? We must do a perfusion scan. Perfusion scan or any advanced imaging. So for us to determine whether they will benefit. Most of the time, kalau dia datang, kalau even they within 24 hours, tapi all the brain dah jadi core. When jadi core, we cannot do anything anymore. So it's actually conservative management. So how do you want to do that? We need to do advanced imaging. And then kalau based on diffuse tree is between 6 to 16 hours. And how do we know that? By a target mismatch profile from CT, MRI, CT or MRI perfusion. Okay, so this is basically we need to do advanced imaging. Tapi just refer if you think that still within the hours that we can do something about it, we can do some advanced imaging over here, and then to determine if patient tak benefit, then we will not do it. So we admit for just a stroke care, acute stroke care. So what are the benefit for mechanical thrombectomy? Is actually a number needed to treat about 3 to 7.5. The latest Aurora study, this Aurora study is benefit for late treatment, and it says that even late treatment also they will have benefit. But when do we see the benefit? Usually we see the benefit at 3 months. So sometimes kita just jangan, although kita rasa masa kita discharge patient still disabled, but we need to follow them up in the clinic to see whether they will benefit from thrombectomy or not. So the timing we see is at 3 months. Okay. So these are the devices you use. So masa we code to patient, sebenarnya kalau our intervention radiologist ini, what we use sometimes they can use, this is what we call catheter aspiration. Basically they sedut dulu, they try to sedut the clot first. Usually usually our radiologist will try to do this one first. This one is murah. Kalau they only use the catheter aspiration, it only cost them about 5,000. Tapi kalau diorang dah tarik, diorang try suction, tapi the clot is not being removed, then baru diorang buka the stand. Basically the stand, they pass the stand towards the what we call the thrombus, and then diorang tarik. Ini yang mahal ni, yang the stand ni yang mahal, about 20,000. So kalau boleh, our radiologist will try to use the aspiration first. Diorang sedut the clot dulu. Ini murah je, 5,000. So if we manage to do this je, we no need to, the patient no need to pay up until 20 to 30k lah for the stenting. Okay, let's see example of the cases. So this is when I was on call on the 6th of November. We got a lot of referral from Putrajaya juga. The first case, this patient is within window. So it's a 55-year-old male presented with a risk factor of diabetic, hypertension, and hyperlipid. So the onset about 9 AM. And then it arrived to us about 11:15 AM, about 2 hours and 50 minutes, just perfect time. So how do they present? They present with the left-sided weakness, split speech, and facial asymmetry. Tapi it's important, the patient tak ada aphasia, dia tak ada visual symptoms. So we already know from the symptom, most likely dia ada lacuna infarct je. It doesn't have a MCA stroke because tak ada this what we call cortical signs. BP pun nice. So satu lagi we have to see is kalau patient stroke ni BP dia mesti tinggi. Kalau BP dia rendah ni can think of something else. Think of what we call either your heart ke as a culprit rather than memang stroke. So memang if you see high BP with clinical stroke, think of stroke. If you low BP, think of do an ECG. Make sure you're not missing an MI or this kind of stuff. And then the pulse is regular, especially pulse regular, tak ada AF, just a pure lacuna, most likely is a lacuna stroke, and the power is 3 out of 5. In terms of NIHS, dia tangan dia actually 3, then 2, facial 1, speech 1. This is a very crude one. Kita tengok upper limb, lower limb, facial dengan speech is enough. For us to this one already 5, 6, 7, 7 dah NIHS. So we know that this patient will benefit from thrombolysis. Let me show you the scan. Scan. Okay. So can you see my scan tak? So so this is our MRI. And so first thing that we can see is our SB1000. SB1000 is what we call a DWI. So this is this patient. As you can see, the stroke is actually sini je. So this is a stroke over the corona radiata and also a bit over the basal ganglia here, over the posterior internal capsule. So we already know that this is what we call a lacuna stroke. So when we see a DWI, we need to see your ADC as well. This is what we call a restricted diffusion. Maknanya putih dekat DWI and hitam dekat ADC. So we know that this is already a stroke. So this is what we call a clinical diagnosis of stroke already. So kita dah, the first kali kita dah tengok benda ni, kita dah tahu this is a stroke. Now this is actually within window. So then we do a flare. Flare ni is another sequence. So kita tengok area tu, ada tak dia putih? So kalau kita tengok kat sini, dia tak ada putih kat sini. Means that this is what we call a mismatch. Maknanya kalau DWI dia flare dia kalau nampak hyper intensity at the flare, means that there's area of match. So this is something that we know that this stroke is still early, and then he will benefit from a thrombolysis, and which we did a thrombolysis for him, and he actually had a full recovery. So these are the patient that we need to catch. Those lacuna infarct, masa kita do an MRA for him. Ada basement MRA. MRA dekat sini dia tak ada large vessel occlusion. So dia just a lacuna stroke. So and then he actually had a full recovery. So dia pure lacuna. Okay, let's go to the second case. Second case is a what we call it's a same, dia datang, both of them came at the same time. So another guy is a young patient, 33 years old. Dia is a wake up stroke. Dia datang, dia bangun dengan stroke. So we don't know the time. They wake up at 7 AM and then the arrival to rescue about 12 noon. About 5 hours post wake up. So even wake up ni kita want to know whether apa nama dia, when is the onset. Most of the time is because usually we kira about halfway before the last known well. Bila dia tidur kita halfway. Tapi di masa dia datang itu 5 hours. So this patient will need an advanced imaging. So they present with the left-sided weakness, facial asymmetry and slurred speech. Tapi dia tak ada aphasia, the no visual symptoms. So we know that this is not an MCA stroke. This is most likely a lacuna. And then BP dia high, regular, there's no atrial fibrillation. Tapi power dia sebenarnya about 4. Kalau I tengok masa that day, I examine dia punya upper limb, lower limb, I bagi 1 je. Dia ada drift saja. Tapi dia tak drop. Dia tak drop to the bed. Then kalau tengok betul-betul, kalau you calculate the NIHS is only 4. Tapi I decided to thrombolyze him because they're young, then I would anticipate the stroke become worse. Let me show the MRI for him. So this is his MRI. Yes, I'm So as we can see here, his MRI loading. Ya, saya kena buka balik. Yeah, I need to open back the image. Satu sembilan. Okay, so okay, can see the image. So wait for it to do. Yeah, this is important yang image dia ni. Tadi I buka okey je. Okay, so you can see so this is the DWI so we can see dia ada stroke kat sini dia besar. Satu benda about this patient is dia ada mula I thought this is a bleed tau because you can see the old one. Apparently dia ada old stroke yang dia tak tahu pun So we think that the current stroke is this one. So this is the coronary attack. If you can see, this is not the typical lacuna because lacuna usually is small tau, tapi ni besar This is what we call a branch erythematous disease possible because you can see dia ada multi-level and they quite big. It's more than 1.5 mm So we blame is could be this the one causing the stroke If you can see from the flare, this is the flare. Dia tak nampak tak hyper intense dekat flare ni So we think that this is the old stroke Yang current stroke is this one yang dekat sini. Tapi this is what we call a mismatch Maknanya dekat flare ni tak ada putih macam ni So this is what we call a DWI flare mismatch This is a flare sequence and the SP1000 I tunjuk balik. This is nampak tak sini this is a new the current stroke because how do we know this is current stroke? Because we ada ADC ni. ADC ni dia nampak dia hitam. This is what we call restricted diffusion on ADC and DWI. Ni dah putih. Maknanya kita dah tahu this is an old stroke. Yang current stroke is this one. And then when we do a flare, kita buka flare, sini tak ada. This is what we call a DWI flare mismatch. So we know that this patient still within early window and he will benefit from thrombolysis and we did thrombolyze him and then he made a full recovery as well. Okay, kalau bukan based on our experience even this the stroke yang besar macam ni it's not your typical the next day dia akan progress dia akan progress and it become more than semi-paralysis so that's why we want to prevent that's the reason I thrombolyze him. Okay, so like go for the third case the third case this is something mild stroke lah. Ni is also been this patient walk in to us dia walk in same day kita orang dah buka dah altiplace kita orang masa tu that day kita thrombolyze 3 patient in a way that we didn't waste our multiplex lah. So this is a dilemma for me. This lady is a 73 years old female. Present dia onset dia not 6:30 and then the arrival to rescue about 8:30, about 2 hours from onset. Tapi presentation dia only slurred speech and also mild right-sided weakness. Kalau I bagi dia NIHHS dia only 4. Facial 1, speech 1, upper limb, lower limb 1. Dia only drift. Dia drift saja tapi dia tak drop. So this is what we call a mild stroke saja. Tapi usually your mild stroke, as we know, we give dual antiplatelet. Thrombolysis in this group of patient, we don't know the benefit yet. Tapi why I decided to thrombolyse her, because dia punya speech very slurred. Kita tak faham langsung. So cakap dengan anak dia, she was very well previously, independent. Although 73 years old, but she's a good 73. Means that they can speak. So because of the speech was so slurred, so let's see her MRI. Let's see her MRI. Okay, this lady, you can see the MRI dia. Dia mana stroke dia? Ini je, kecil ni je. Over the centrum semi-ovale ni. So small. So and that causing the symptoms. Because as we know kan, kita tahu kan, dia punya symptom just slurred speech, tak ada cortical signs. We know. So this is the stroke. And then when we do a flare, kat sana nampak brain dia dah atrophy sikit. Makcik ni dah a bit ada memory problem. So, sini tak ada apa-apa. Quite wide. Means that still early. So and because of the lesion is so small, I took the risk because I know that kalau stroke besar macam ni, dia orang takkan bleed. They will not bleed. Even they bleed, this area is so small. So I'm not worried. So I decided to thrombolyse her. When we follow her up, dia tak ada banyak sangat recovery. So those are the patient that kita tahu some will get benefit, someone will not get benefit. So maybe this patient did not get so much benefit, but the good thing that she did not progress. How about the fourth case? The fourth case is very unfortunate. It's a 43 years old male. It was referred by us by KPJ Kajang. The next day, masa I call juga, the risk factor, dia ada previous stroke, recent thalamic stroke in September 2021. The onset is 5:30 AM. Dia datang awal, pergi hantar KPJ, dan KPJ send to us. So arrival to rescue around 10 AM, which is 5 hours. So when they send me the CT scan, diorang dah buat CT scan, dah nampak the hyperdensity dekat area tu. Tapi the difference between him, he has aphasia and dense left hemiphasia. As we know that someone with aphasia, and then when kita examine dia, the aphasic and the right grace preference. We know that this is a MCA stroke. And then the NHHS is high. So we already alerted everyone, tell them that this is actually going to be a possible intervention. Let me show you the MRI. So when we did the MRI for him, tengok dia punya stroke tapi ni dah huge dah. So masa dia datang, dia dah besar. Kalau kita tengok the area of stroke ni is actually more than 1/3 of the brain already. So this is the area of the stroke. So when we do the flare, tapi masa kita buat flare, kan nampak flare dia still okay lagi. Means that this patient is still boleh. Tapi why I didn't decided to thrombolyse him, because I already dah worried dah tengok benda ni. Kalau I thrombolyse dia akan bleed lah. The area of stroke ni besar. Quite big. So when we did an MRA, dia ada actually what we call a distal occlusion. Dia okay juga, dia MCA dia okay. Tapi dekat distal ni dia ada some occlusion. So he's actually an M2 occlusion rather than an M1. So because he came 5 hours and then from the stroke pun dah besar macam ni. So we decided to direct angio dia. Masa we did an angio, our intervention radiologist tried to do a thrombectomy, but diorang kata masa diorang masuk dalam tu, the area of ni semua dah core. maknanya there's no area for them to save. So in the end, we didn't do anything for this patient. We only did angio, and then conservative. We are worried that he might need decompression cranectomy, because he might develop a malignant MCA, but he did not. So so he actually discharged dengan still quite disabled lah. So we will send him to intensive physio. So this is an example of cases where we can see from apa nama dia, whether it's a within window, whether it's a wake up stroke, mild stroke, and huge MCA. And how we decide that? We usually need advanced imaging, and then from the clinical history itself, we can determine whether patient for thrombectomy or for thrombolysis, and then we can alert people to be prepared, so that we don't waste time. Again, I would like to emphasize this cartoon. As you can see, not everyone will benefit. Like for example, from our case, only 2 patients benefit, the rest did not benefit, and that one guy is actually become worse. Become worse atau dia become sama je. Okay, I think with that I thank you, and then I'll open the floor for any questions.
Okay, thank you, Dr. Hanif, for such an interesting sharing from your side. It is nice to know the cases that we sent to you has with good recovery, and patient really benefit from the intervention that you guys have done. That's very awesome. So I would like to open the floor to ask Dr. Hanif with any question, any burning question that you have been keeping in your heart maybe. I think this is a very good opportunity for us to share and to expand our knowledge. You can either type it inside the chat box, or you can unmute yourself and ask Dr. Hanif personally. Is there anyone? Okay, Hanif, kalau tak ada, I tanya dulu. Maybe somebody need to start. So just for the clarification purpose, I'm always confused between dysphasia and also dysarthria. I thought dysarthria is specifically only for cerebellar disorder. So can you clarify on that, on how do we decide on these two?
Sebenarnya dysarthria is any facial problem. I mean, someone having facial asymmetry, they will have dysarthria because they cannot really speak. And even your Bell's palsy pun, they will have dysarthria, because your lips are responsible to say ba ba, so they will become dysarthric. Kalau dysphasia, kalau kita tengok NIHS punya paper tu, there's few things that for you to assess dysphasia, they cannot name, they cannot read, they cannot apa nama dia, they cannot dysarthria, dia still boleh baca, cuma dia not fluent lah. Diorang, kalau kita suruh cakap, kita akan suruh cakap diorang Perlembagaan Malaysia, and then Perpustakaan Malaysia, because all those perlembagaan, perpustakaan using your lips. Any speech, apa any perkataan yang using your lips, baba ni dia your seven nerve palsy. So they are dysarthric, tapi dia boleh baca, dia boleh namakan benda, quick things that you show them pen, what is this, if they cannot name or they find it difficult for them to express, those are dysphasia. Kalau dia boleh cakap lagi, cuma cakap pen, cuma nampak pelat, so those are dysarthria. So dysarthria doesn't necessarily must mean your cerebellar. It's just your facial asymmetry and your facial weakness causing your dysarthria.
Okay, all right. Thank you very much. We have one question in the chat box from Dr. Wan Faraliza. Hi, Dr. Hanif. So UPM use both Altiplase and Metalase. How do you decide to which one to use? This is very interesting question. Yeah, so which one do you decide?
At the moment, we only have Altiplase. TNK dah habis. And then TNK is not in the circulation at the moment. TNK mainly in the cardio for the use for what we call for MI. Actually, TNK is not licensed in Malaysia yet to use in stroke. So a lot of our patients, we use TNK. We need to apa nama dia Metalase and Actoprise. Okay, we need to use it as off-label. Okay, so tapi the good thing about TNK ni is that the good thing about TNK ni, dia actually apa nama dia senang. Kita give one bolus je, dia tak perlu infusion. So when we had we still had TNK in our rescue, we try to finish our TNK because it's easier to be administered. And then we find it better outcome. So lepas ni maybe we want to push to buy more tenecteplase rather than alteplase. It's because sebenarnya both of the alteplase and TNK ni daripada same company. So sebenarnya it's a bit of political there jugalah. So the company are giving more alteplase rather than TNK. So those are the things that and then TNK dah start ada generic, so they don't want to. Yes, we are actually ada FRGS on that. One of my colleague, Dr. Janudin, he got an FRGS on doing TNK. So we try to get TNK to compare to alteplase. Tapi sebenarnya dah ada a lot of research dah ongoing that, and they actually say that using TNK is not superior, not inferior, or even actually quite superior pun compared to your alteplase. So actually if we have TNK, we prefer that. Because senang je, bagi one bolus je.
I hope that answer Dr. Wan Paraliza's question. One more question for me, Hanif. Unfortunately, even though we have all this intervention and also latest management for the stroke, patient with a stroke disorder, how about those patients that are not able to pay? So in a way, we have to do a CT brain and somehow just start them on a prevention therapy, which is the most commonly used would be aspirin. So how fast can you start the aspirin for the patient, and does using an aspect score will be part of the consideration whether you want to start an aspirin or not for this patient?
Okay, actually, as we know now, especially if you're mild stroke and high risk TIA, we prefer to give them dual antiplatelet. The latest from trial, we give even with the low NHHS, kita bagi dual antiplatelet for 1 month, then we give single. Even for your single antiplatelet pun, even kalau you dapat this a clinical stroke, CT brain, even if it's a big stroke, there's no contraindication for you to start aspirin immediately. Okay, even a huge MCA, if you're not planning to do anything, then just start the aspirin. There's no contraindication. So how do you want to help this patient? Because the good thing about Putrajaya is a lot of people pergi sana ada GL, so kita senang je kat sini kan. Tapi now we are working with our Perkeso, especially with in Serdang and also in Kajang, patient with SOXO, at least SOXO kita ada communicating with them, then SOXO boleh cover, especially kalau thrombolysis and thrombectomy, even with the dengan inpatient stay as well. So those are the things that under our belt at the moment. We try to help our patients lah. Now with the, and also we also have One Hope. One Hope itu pun, this is actually lebih kepada patient kat Sedang ke atau kat Kajang lah. Sebab Putrajaya actually patient are still quite affordable. They, especially yang patient dekat Sedang atau Kajang memang tak ada duit langsung, we can actually call One Hope to help them. So those are the few things that we really looking forward to do lah. Kalau Perkeso masuk ni lagi kita orang happy. So Perkeso can help them.
Yeah, that's great.
Dr. Nozila asked level of awareness. Saya rasa memang sangat-sangat. I think even we did our virtual run hari tu pun, a lot of people, I think this is not, I think lebih kena ada national punya interview, the KKM must do something, masuk kat TV ke, inform about fast, those kind of stuff. So I think people still don't take much attention with stroke. Heart attack, they know it's pain, so they need to come. So tapi kalau stroke ni kadang kat rumah dia tunggu anak dia balik rumah, those kind of stuff. So a lot of, I think we need to create more awareness lah. Any data on door to CT brain, sebenarnya ada, tapi I actually don't have it with me at the moment, because even the latest hari tu pun when they did a conference tu ada, we can actually show our data, but I don't have it with me at the moment. So still kalau bukan not the dedicated center, even to send to CT pun quite long. Okay, minimum need how much to admit UPM? Ini kalau tak ada GL ke just cash paying?
Okay, I'm not sure GG ni doktor daripada mana, saya tak sure. But dia kata both. Not sure. Actually, you can
Okay.
direct to everyone or Dr. Hanif.
Oh, kalau GL apa nama dia free lah GL tak ada masalah. So it's been covered GL pencen anak kerja kerajaan semua not an issue The only thing that need to pay is sometime for the thrombectomy for the stent. The thrombolysis, angio, everything is covered. Kalau cash tu is a bit more expensive, especially kalau kita perlu masuk ICU so dia kena ada deposit about 5,000 and then even for the deposit for the imaging they need to put what 1,000 kalau nak quote to them, kalau compare thrombectomy and everything around 30-40k jugalah.
Okay.
Itulah, we are trying
Yeah.
too much trying our best to actually for reducing the cost, because you know that this is a university hospital so
Yeah. Okay, sure. Do you have any more questions? Because I think we already touched 10 o'clock. Yeah, I think there's no more question for you. Thank you very much, Hanif, for spending your time with us to enlighten us about this stroke, because we have new people coming to Putrajaya, and actually I shared this with my colleagues in Sabah as well. In Sandakan, where I used to work before, we do not have any stroke thrombolysis pathway, unfortunately, but once they got back here, I hope that they will be able to join your networking. All right.
okay.
So we hope that we will have more sessions, Hanif, inshallah in future.
Boleh. InsyaAllah,
Okay,
insyaAllah.
that's great. That's great.
I think Dr. Alwi also here. Dr. Alwi, later I will text you.
Alright. Okay, so kalau tak ada apa-apa, I would like to thank everyone for joining today. And since this is a recorded version, I will upload it inside the Neuro Emergency SIG group Facebook and also in the YouTube. So any last word, Hanif?
I'm very happy with our collaboration with Putrajaya, and kalau boleh send patient as fast as possible. So that's my only
Alright.
thing.
Okay, thank you very
Okay.
much. Alright.
Thank you so much.
Okay,
Thank you,
bye
everyone.
everyone. Take care.
Bye bye.